Looks good. Whoever else can squeeze in the other elevator. TV's in the first elevator. Everybody else who can sit. TV's only here. Get everybody in. TV's first, and whoever else can fit. Keep coming. Keep coming. Keep coming. Keep coming. Keep coming. Let's go. Let's go. Keep coming. Keep coming. Keep get in two. All right, keep coming. Yep. Okay. Second elevator. All right. Up to 3. Thank you. We're in 3 to the right. This way. Please follow me over behind. To the center. Right here. Okay. Yeah, that's her first stop. That's her second. Okay, TV's there. Still, trusty hand.
God, I'm getting it. I wonder if I should turn my oxygen on.
Guys, everyone has to be inside. All right, now we're
Okay, so we're gonna move everybody, making sure everybody got a spot. Does everybody have enough room? We can move down a little bit. I know it's a tight squeeze, we talked about it earlier, so just, there'll be 2 sections. She'll be on this side and this side, so we'll be able to get shots, and we'll be able to move this after the first pod so you guys can move out wide, but not forward, okay? Out wide, not forward.
¿De dónde va a entrar? ¿De aquí o de acá?
De por acá,
Ok,
para
ok.
aquí. Vamos a recorrer así, nos vamos para allá.
Hi guys, how you doing?
Good stuff.
Good, and you? I wish I was a lefty.
Y sí,
We're going to start over this way.
Okay, we'll go back when I do.
So let me introduce Dr. Biden. This is Ramon Cancino, who leads our efforts in cancer
Hello.
prevention and screening. Jeanette Sanchez is one of our community social workers. And this is Rainey Miller, one of our patients who was impacted during this time of COVID for her cancer screening. I'll leave you with Dr. Cancino to share with you a little bit about how we tried to reboot cancer screening during the time of COVID.
Sure, yeah, so Dr. Biden,
Can the press all hear? Can you guys all hear?
Perhaps I'll have you
I think
have
that's your
Oh, yeah. Look at my little blue X. Okay,
So Dr. Biden, we're just so happy and thrilled that you're here,
thank you.
especially in such a busy time in our country. Thank you for allowing all of us to share our story. My name is Ramon Cancino. I'm a family medicine physician here. I'm our primary care center director. And I was asked by Dr. Ruben Mesa to work with a team to integrate cancer prevention and screening across UT Health San Antonio. And I co-lead a committee of medical specialists who really focus on cancer screening, prevention, especially as it relates to cancer equity issues that we know our patients experience. And so at the beginning of the pandemic, we were concerned that our patients would delay their cancer screening.
Sure.
And we brought this concern to our colleagues, and our institution responded. UT Health San Antonio increased its efforts for proactive outreach to patients who would have delayed their cancer screening, as well as patients who canceled their appointments for concern of getting the COVID-19 infection. And so our physicians went on television, on radio, and on social media to spread the word directly to patients that it is important to get your cancer screening even in the middle of a pandemic. We partnered with our affiliate partners in the community, including University Health System, as well as the American Cancer Society in this effort. And our primary care locations actually expanded their hours and leveraged telemedicine, specifically video visits and telephone visits, to allow our patients to get the care they need in the middle of the pandemic. Thankfully, our practice is a patient-centered medical home. We work directly with our nurse care managers, clinical psychologists, and community health workers to ensure that our patients don't fall between the cracks, as well as to allow them to be linked to the care they need in a timely manner. And this is all important because we know that if we find cancer early, we can get them to places like Mays Cancer Center,
Sure.
like folks in this room, who can get treated as soon as possible. And with me today is Jeanette Sanchez, one of our community health workers, who's helped a lot of patients get the care they need in her time of need. I'll let her tell you about her work.
Hi, Dr. Biden.
Hi.
It's so great to meet you. I'm so excited you're here.
Call me Jill, okay? If I'm gonna call you Jeanette, you gotta call me Jill.
Yes, ma'am. So one of the things that I love about my job as a community health worker is outreaching our patients, building those relationships and connections. They're really important because I serve as a support system to the patient and their family and helping them access their care, outside resources, and just providing support, maybe being a listening ear for them. So during this pandemic, we increased intentionally outreach to patients to see how they were doing, if we could connect them to resources, whatever it was that they needed. And one of the consistent themes in the phone calls that our team found was a lot of people were putting off their health care. That was backseat to just daily survival. So what we thought was, if the patients can't come to us, why don't we bring care to the patients? And well, the big thing was screening for breast cancer.
Sure.
So we partnered with University Health System, and they brought their mobile mammogram unit out. We did deliberate outreach to women with mammograms that were overdue. We were able to get 25 women screened at our event, and of those 25, 5 of those were abnormal results. So possibly the team saved 5 lives.
Yes.
And so that's the best part of being a community health worker. Right now, I'd like to introduce to you one of our primary care patients, Ms. Rainey Miller.
Hello. Hi,
She is a patient of one of our primary care at the Chavano Park Clinic. And she has a story, her story she'd like to share about screening prevention mammograms.
Okay, well, kind of nervous. I just want to emphasize the importance of being, I'm sorry, I'm so nervous. I'm so sorry. I think you should just be the #1 advocate of your health. You should really be in there. It's a full-time job. I really love the UT system. We have the My Chart where I can get on and see everything that's going on. All my doctors in the UT system can get on and see what's going on. I was able to get my mammogram, get the results back, a certified letter, and get my biopsy, I was referred to Mays, got my surgery, got my results, and was on therapeutics in 6 months. And for me, that was very important because I have other very serious day-to-day health issues. I needed to get it done and get it over with and get on with my day-to-day. And I have great kids that I want to spend time with. And so that's why.
I want to spend time with you.
Yes, I love them so much and I want to spend more time with them. And that could have become something more severe that took my life. And I've already had enough of those incidences. And so I'm very grateful for the UT system. I was telling the director that I had not been in the UT system until about 2 or 3 years ago. I've had health issues for 33 years. And so I am very impressed with the way that everybody shares data, and I think that is part of the moonshot goals, is to get data sharing, is from what I read. And so I think
love that you read the literature.
Well, I wanted to know what initiative you were working on, so I got on and was reading up on it, and I hope it's continued.
Yeah, oh,
Because I
yes.
think this is the 7th year, correct?
Yeah.
And so I don't know if you're going to continue the program,
Of course,
refund it.
It's the purpose of
Okay.
my life.
I'm hoping it's going to be refunded because it looked like this was the last year. So anyway, I'm very impressed with the UT system and how, I can get on televisits very simply with my primary care physician, and she's been great speaking to me and keeping up with me. And, Mays has been awesome. This place is just an awesome place to be. They really take care of you. UT hospital really took care of me. And like I said, the sharing of data,
Yes.
I think is the #1.
And getting into trials.
Yes. Well,
Early
I haven't been in a
detection.
trial, but yes. And just, the fact that my primary care physician can get my results from my lab quicker, everything goes so quickly that you get things done in a timely manner so that it doesn't become more of a serious health issue.
Yeah.
So that's what I'm really impressed with.
Well, we're
That's
impressed
wonderful.
with you.
Thank you.
Thank you so much. Thank you so much. Dr. Biden, let me introduce you to our next group over here.
Okay.
Please.
Thank you so much. And
Oh my God.
6:30. Reading and language.
I'll be there tomorrow.
Oh my
8
goodness.
o'clock.
Thank you, Ray.
Thank you so much.
Yeah, thanks.
Thank you. Thank you, nice to meet you.
So now one of the key initiatives here at the Youth Camping Center.
Oh, God.
They were gonna split the set. They said,
Yeah, just a little bit.
just to that, they said they were gonna stop with them.
So let me introduce
Did I tell him?
the Enterprise Project. The Teaching Paradise is the director of our Teaching and Family Services.
Dr. Biden, it's an honor to meet you and a pleasure to share some details about Mays Cancer Center. It is our goal to promote health equity to all our patients, diagnosis and treatment, but beyond that, to a full comprehensive care approach. The Mays Cancer Center did create the RISE Project. It's a collaborative, holistic suite of patient-supported care services in parallel with medical specialty services with a focus on cancer. The patient-supported services provides emotional support, financial support from our social workers. We provide parking validation, transportation, and emergency lodging for those that need assistance to come in. And lastly, our dietitians use our instructional kitchen to provide nutritional medical therapy.
I know, I love that. I read that in your literature.
Thank you, and they're very dedicated and passionate about their work. That's often not covered by insurance, but they're teaching patients how to use feeding tubes and how to optimize their nutrition. And what makes us unique is the suite of services is embedded in our primary care clinic services, our cardio-oncology, nephrology focused on cancer, survivorship care, and cancer rehab. And next, Dr. Brian Cricky will talk a little about the cancer rehab project.
Thank you.
Dr. Biden, it's an honor to meet you. Thank you for taking the time to meet with us, and it's a privilege to welcome you to the Mays Cancer Center and have the opportunity to talk with you a little bit about what we do in cancer rehabilitation. So, I'm Dr. Brian Crookie. I'm the Director of Cancer Rehabilitation here at the Mays Cancer Center. And cancer rehab, to give you some background, really thanks to the tremendous advancements that have been made with cancer treatment and the top-notch care delivered by the oncology teams across the country, like those here at our Mays Cancer Center, survival rates among patients has grown exponentially. It's projected by 2040 that there will be over 26 million cancer survivors in the U.S., with as many as 60 to 90% of those individuals living with some kind of impairment that adversely impacts their functional independence and quality of life. And so cancer rehabilitation is a subspecialty out of rehabilitation medicine that's grown out of this recognition of this gap in the cancer care community. And so it comes with a lot of challenges being in this new emerging field of study, but a lot of exciting opportunities as well. One of the most exciting things that I'd like to share with you is with cancer rehab, we really examine the impact of exercise in cancer. And so while we know that exercise can serve as a protective factor against many types of cancer, and can also help with preserving loss of function during cancer treatment, some early research suggests that exercise during cancer treatment can even potentially help pause the therapeutic effects of cancer treatment. And so we're very excited by that. As a cancer rehab physician, I treat patients with a variety of impairments, things like chemotherapy-associated neuropathy, radiation fibrosis syndrome, fatigue, and individuals like Ms. Ford here with lymphedema, just to name a few. So lymphedema, to give you some background on that, is a common complication after breast cancer treatment, characterized by abnormal swelling of the limb due to collateral damage done to the lymphatic system during treatment. And so with that can come a lot of functional mobility deficits in that limb, impaired use of that limb. It serves as an unpleasant, often anxiety-provoking reminder of patients of their battle with cancer, and can put them at risk of severe soft tissue infections that, if not identified and treated early, can be very dangerous or even life-threatening in some cases. And so Ms. Orr here has had tremendous improvement in her lymphedema following recent lymph node transfer surgery conducted by one of our plastic surgery colleagues here at UT Health in San Antonio. And that's one of just several surgical options that we have available for the treatment of lymphedema. One of the biggest challenges we still face with treating lymphedema is the necessary compression garments that play a real central role in treating lymphedema.
I've had a lot of friends who have had that. A lot.
Yeah, and the garments unfortunately are not covered by insurance. Oftentimes patients need to pay out of pocket to get those garments, and they play a really key role in adequately managing lymphedema. So with that, I'd like to turn it over to Mr. and Mrs. Bohr to talk to you a little bit about their personal journey with lymphedema.
Hi,
Hi.
my name is David Orr. I'm married to Cynthia. Cynthia got cancer 10 years ago. We got treated in MD Anderson.
No, it will.
One day, 9 years later, cut the stomach. Small cut. No big cut. Her arm got as big as her head. Found out from all the surgeries that they've done, they cut them all out. All the lymph.
Yes. Yeah.
So, at the beginning, we went up to get them, right? Then, we found out the next day, all right, we got to go back. Well, 10 years ago, she spent the better part of 6 months to a year up. I was going to say, so. That was tough.
I know.
Tough. So I tried to figure out a way to keep her here. So I spent the better part of the whole day calling everybody. I found this man.
It was your godsend, right?
Exactly. They figured out how to fix her. They took a lymph node from here and put it in her arm.
Pretty amazing.
And, you know, her hand went from going to like the puffball or whatever. I mean, it was swollen. And it hurt. She's a southpaw, so typing and everything. They did that thing, and they told us maybe in a year you might see something. During that surgery, they didn't figure it out. The vein or whatever that fixed with it, she got fluid and all that. They reattached that. But she's showing right away. I mean, we're talking. So, you know, hey to you and Joe. I'm sorry about both.
Thank you.
All of it.
So,
all right, I'll leave it to her now. She'll tell you.
He covered a lot of what I was going to say. I have some notes.
Typical like
I
a
cover
husband,
everything.
right?
Yes.
Take your thunder.
I am a southpaw, and I do write and type for a living. I'm a lawyer, and it hurt tremendously to perform my job. It was just so
Sure.
And to learn that we had Dr. Pritchett here in San Antonio was amazing. I didn't know Dr. He specialized in cancer rehabilitation. And yet here we are on the cutting edge, advancing that medical science so people can have relief from what we call side effects, but are much bigger problems because they haunt us for years and linger years after we think we've beaten cancer. Now that I can wear suit jackets again, and people don't ask me about my arm, I don't have to speak about my cancer every day. I don't have the pain in my arm anymore, and with compression and other treatments, I now have joy in my feeling. I hadn't realized what a burden the symptoms were until I was relieved of them from where I received care.
Well, it's terrible to be in pain all the time. You know, you don't realize you take on like this a pain for something, right?
So that's right. It's well put. You soldier on, but you have no joy in life. I was also distraught because I learned that people that don't have resources like David and I do couldn't afford even those compression wraps, let
I know,
alone
isn't it horrible?
the garments. It's awful. So David and I like to help people, so I knew I had to share the information about Dr. Fricky and cancer rehabilitation medicine, and about advocating for getting the coverage for the treatment garments. So I support a bill that's now in Congress to provide Medicare coverage for lymphedema treatments. I'm going to be proposing a resolution at the ABA House of Delegates that also helps guide Congress, and I'm going to work with my Chamber of Commerce too that does SA to DC. I'm also sharing information about the availability of rehabilitation medicine, writing articles and working to get that widespread information out to patients who know or need to know they can get their pain and their side effects alleviated from this important treatment. And most of all, I want to tell Dr. Fricky and the Mays Cancer Center how grateful I am for their knowledge and care.
So look how you turned something that was negative into something positive. You found purpose, you know, and now you'll help other people. So thank you.
Yes, indeed.
Thank you.
Thank you for being here.
Dr. Fricky, you said 30 million cancer survivors in like a decade, is that right?
Yes, sir.
And what do you
yes.
how many do you think there are today? Like 10, 12 million, something like that?
Today, the best estimates are there are around 18, 19 million.
Right, so this is kind of close to double, which
Yeah.
I guess in a way it's good news that we're curing so many people and they're living longer, but you know, a problem that we didn't plan on having is now people are getting long-term complications, so this is so important.
Yeah.
You know, it's a critical piece of why we really are trying to bring together all of the medical specialties, because again, this long-term piece, survivorship medicine is its own discipline really within primary care. Cardio-oncology that is critical, onconephrology, issues with the kidney, nerves, brain health. So again, it's a very important, kind of evolving part of general medicine, evolving out of really traditional cancer care.
And in a city like ours that has such tremendous equity issues, having the team at UT Health dedicated to placing all those resources within San Antonio has been critically important, as Dr. Hendricks will tell you from personal experience.
Makes a big difference.
Families that don't have the means to stay 6 months out of the year in Houston now can get the world-class quality care here. And I will say, from Jeanette's work, everything is being viewed right now through the lens of COVID. Those community health workers, our city has a very hard to reach population, and so the community health worker model has become the model for delivering health care, to getting information out to people on vaccines, testing, even housing and utility assistance, using that model in many other aspects.
Something that was said earlier by you is compelling to me, and that is when you can get your care close to home, it aids healing tremendously. It helps you heal when you're around family and friends, and that you found it here is particularly gratifying to see, and a great result. So all better for this reason.
Sorry.
No. Thank you. Thank you so much. Thank you. Good luck to you. Thank you. Thank you. He is working hard. He is, but he's got a lot to work on. You know, there's like every day we wake up, there's something new. Thank you. Thank you. Thank you.
David, thank you so much. That was great. Thank you.
Much better, David.
Thank you. That was fantastic.
Doing all right. Thanks for your advocacy. Doc, very nice to meet you.
Thank you. Great job. Great job.
I was
I didn't have an angle. That's dirty, huh? It's dirty. He needs the exercise.
Let's go, guys. Let's move quickly. Let's move quickly, guys. Guys, let's move quick. Michael, you it? You the last person? Okay. Let's go, guys. Let's move quick. Move quick. Move quick through here. Let's go. Quickly.
They just want to like have their like downtime and do that. It's the best.
Puerto Rico. And so those are the 4 planning committee members.
Work and study.
Cameras up on tripods. There's a mult box. Guys, Steve, you guys know what a mult is? My San Antonio Express. Right here. Sick, you all right? I'm Harvey. Good. You all set? You guys all set? TV's all set? Guys, you're gonna stay in here the whole time. Till she leaves. We all set? Keep an eye on him for a second. I want to let him know we're all set. Everybody good? Because she's gonna walk in any minute.
Said a couple minutes.
Hey, I'll take that side.
I think she's holding. I think
of the Mays Cancer Center, let me extend a hearty South Texas welcome on behalf of the Mays Cancer Center to Dr. Jill Biden, our First Lady of the United States, Director Ned Sharpless of the NCI, Mayor Nurnberg, our elected officials, President Henrich, colleagues, institutional leaders, and guests. Now, why are we here? We're here because cancer is a thief. It steals from our patients and their loved ones length of life, quality of life, and cherished memories that have not yet been made. Now, Dr. Biden and President Biden have called on us to end cancer as we know it. So how do we do that? Teamwork. It takes a team. The Mays Cancer Center is proud to have been a critical part of that team since 1974 when it was founded, and since 1991 when it received the highly impactful designation as an NCI Cancer Center. Now we try to make a difference in that mission first by focusing on the 4.9 million individuals of South Texas, 69% Latino, and the cancer issues in that region. We focus on South Texas-focused cancer discovery. What cancer is occurring in this area? What do we know about the biology? How do we advance through our science, the ability to screen for cancer in a way that is feasible and help to overcome barriers that our patients can experience in undergoing cancer prevention and screening. We focus on the development of the next generation of cancer therapies delivered through clinical trials and others, whether that be immunologic, cellular therapies, radiologic. Texas-focused cancer hospital that'll be a unique resource for this area so that people no longer need to leave this region to receive complex, life-saving cancer care. We focus on patient-centered, holistic, complex cancer care. You heard from one of our patients, again, that had breast cancer, cardiac disease, and other difficulties. It takes a village to be able to provide this complex care and to be able to support that through cutting-edge research. And then finally, but not least, we focus on advancing the science of cancer in Latinos. We're uniquely positioned to study this and to share these outcomes with the rest of the community. These panelists around you and my colleague, Dr. Emily Ramirez, our Associate Director for Community Outreach and Engagement for the Mays Cancer Center, the co-founder of our Advancing the Science of Cancer in Latinos meeting, to which this discussion is being beamed as we speak, is helping to lead this national conversation with people from around the country. Together, we can end cancer as we know it. Let me hand the baton over to Director Sharpless.
Thank you, Ruben, and I want to thank everyone for a very warm Texas welcome, although the warm is metaphorical, because it turned out a little chillier than we expected. But still, it's great to be back in South Texas and to see everyone at one of America's great cancer centers, the Mays Cancer Center, an NCI-designated cancer center, and it's really exciting to see the work done here. It's the intersection of community engagement with hardcore science, with patient care, and it's really, comes together nicely to take great care of people with cancer. As I've said many times, this is sort of a golden age of cancer research we're living in. I think the decade that just passed and the decade that's going to come we'll remember back as a period of remarkable productivity in cancer science for lots of reasons: a new and improved basic understanding of cancer, a great work of clinical trialists, a significant industry interest in this topic. But I think one really important aspect of this is to have this commitment in the White House from the President and First Lady and the Vice President to end cancer as we know it, to make this a top priority of this administration. And the President spoke very eloquently about this at the beginning of this February at a kickoff event to supercharge the cancer moonshot, and that has been so exciting and galvanizing. One of the things the President specifically spoke about was dramatically reducing cancer mortality, cutting it in half in 25 years, which I think is very doable. Another thing that the President specifically called out is this need to have a return to screening, that is cancer screening for breast cancer and colon cancer and cervical cancer and lung cancer. We think we missed on the order of 10 million screening events during the pandemic, and we need to make those up so that we can save lives. We can have people get diagnosed earlier and not present with late-stage cancer when it's harder to treat. And the First Lady has been a clarion voice on this issue. She has been so strong, talking to lots of people, going on the various media shows and whatnot, sounding the alarm that we need to return to screening and get back to cancer screening, and she's been such a friend of cancer research and cancer care. So it's my pleasure to welcome her and to bring her down to South Texas to see a great cancer center.
Oh, thank you. Thank you, Dr. Sharpless. Ned and I have been traveling the country, really, to get the word out and to do forums like these. And thank you, Dr. Mesa, for the tour today. And thank you to the whole Mays Cancer Center, really, for everything that you're doing. And thank you, Mayor, for being here and for bringing Erica with you. I really appreciate it. And, cancer, like they both said, did not take a break during COVID. And that's especially true for people of color. And, one of the things that the White House has been focusing on, like you say, is the inequities that occur in so many of the communities across this country. And cancer really, I bet, touches every single one of us. But it doesn't affect every community in the same way. And that's why, as a part of the Cancer Moonshot, I'm glad to learn today what we're doing for the Latino community and what we will continue to do and what you all are doing. And, we're going to keep, one of the things I'm going to do, Joe is going to do, is keep having these conversations with, the Latino community, the Native American community, tribal nations, and the underserved communities across this country. And we can do better. We can do better. And that's our mission, that just like you said, end cancer as we know it. So I'm really excited to hear about what you all are doing and take it back to the White House. And, Ned and I will take it back and see what we can work on. And I hope the people of Texas have heard what you've said in that, we've been in this COVID pandemic for 2 years, and so many people put off their screenings. And so now, the numbers are rising. We've got to get them back down. We have to get people in because, as I've always believed, early detection is really the key. It really is the key. So anyway, I'm so excited to hear what you're doing here. So Dr. Ramirez?
Great. Thank you so much, Dr. Biden and Dr. Sharpless. We're really excited to have you all here. What a great opportunity. Bienvenidos a San Antonio. So thank you so much for being here. I just wanted to share with you that I am very passionate about Latino cancer health disparities. I won't tell you how many years I've been working in this area, but it has affected my family. It has affected a lot of our friends as well. And so I have really been working to instill new ways to really look at this population that's almost invisible. Yet we represent 18% of the U.S. population. We are now the largest minority population in the United States. And, within a few decades, 1 in every 4 individuals will be Latino. And cancer has become the leading cause of death for our community. And it's expected to increase by 142% over the next decade. So we truly have to do something because the cancers that we're diagnosing are really, all cancers are devastating, but we're seeing, for example, liver cancer at twice the rate compared to other populations, stomach cancers. And I used to call these orphan cancers, but they're really cancers that are just less studied because we don't have the appropriate biological treatments available for them. And so we need to do so much more. And then when we see, breast cancer and prostate are actually lower rates in our population, but the survival outcomes are not as good. And so this was really what led me to say, why is this happening? Is it just access to care? Is it social determinants? Or is there something truly biologically going on that we need to know more? And I'm really hoping that the NCI sees this and this investment is really critical to us. And that's what drove me in 2018 to start a conference on advancing the science of cancer in Latinos. So today, we just kicked off our 3rd biannual conference. Yes, thank you. We have over 200 participants that came, considering. It was really hard to decide whether to go virtual or in person. I checked with all the infectious disease docs, and they gave me a thumbs up. So you could just see the excitement of coming together. We have scientists, junior faculty, we have community members. We realize it takes a whole workforce to make these changes happen. And today with me are three of our planning committee members who I would like to briefly introduce. Dr. Patty Moreno is with the Sylvester Cancer Center at the University of Miami. Dr. Barbara Sagara is with the University of Puerto Rico, and Laura Fetterman is with the University of California at UC Davis. And each of them has just been a valuable partner for us in putting this conference together. And if you could have just seen the excitement today and the exchange that we had, it was really great. But we are beaming you, so this is, the participants are getting to see you today, and they're really excited that we had this opportunity. So before asking Dr. Moreno a question, I just wanted to share that we are doing and funded by the NCI, the first national study to look at Latino cancer survivorship issues. It's a partnership with the University of Miami and the Mays Cancer Center. We're going to be recruiting over 3,000 Latinos who are cancer survivors to better understand some of their psychosocial needs, some of their other kinds of personal needs and during their journey of cancer. So we're really excited about that opportunity and grateful for the funding. So I'd like to maybe turn it over now to Dr. Moreno just to ask you, can you share a little bit about the unique program that you're doing called My Wellness Check?
Thank you so much, Dr. Ramirez. And first of all, I'd just like to take the opportunity to express my deep gratitude to Dr. Biden for the opportunity to discuss our work, and to Dr. Biden and the President for their continued commitment and support to cancer research and innovation. So at the University of Miami Sylvester Comprehensive Cancer Center, we are implementing innovative approaches to incorporating the patient's voice into their cancer care so that we can effectively address their quality of life. As a clinical psychologist, I'm very concerned about how well someone is living while they're undergoing treatment, or even once they've completed treatment, in addition to the important biomedical advances that are happening within cancer. Of course, receiving a cancer diagnosis and undergoing treatment can significantly impact quality of life. We know that there are symptoms and side effects that can occur commonly, like pain, fatigue, anxiety, symptoms of depression, or declines in overall physical functioning. And we know that that affects someone's quality of life, their ability to continue on the treatment at the sort of regimen or dose that is prescribed, as well as impact, of course, their emotional well-being. So at the University of Miami, we have created an initiative, like Dr. Ramirez said, that's called My Wellness Check. And our focus is to routinely assess symptoms and care needs in patients when they are undergoing cancer treatment. The focus here is to really be systematic about assessing these domains of well-being so that we can address them early on. So prior to an oncology appointment, patients are completing standardized measures that were developed in collaboration with the National Institutes of Health to assess different domains like symptoms of fatigue, pain, depression, anxiety, and physical functioning, as well as care needs. Care needs are issues that patients say that they want more information about or that they want more support about. So these things can be practical, like help with transportation or help navigating insurance coverage and their finances. They can be nutritional, so wanting more information about what vitamins and supplements they can take, or a desire to meet with a dietitian. Or they can be emotional, wanting more support about coping with the illness, how to talk to their family members, or manage stress. And they complete these assessments online, either at home from the patient portal that we have as part of their care at the University of Miami, or after they check in for their appointment before they are seen. They take very little time to complete, even though we're getting a lot of really rich information from them. It takes about less than 5 minutes because of the innovative ways that they're able to be captured from much work that was done by the National Institutes of Health, so that not every single person answers the exact same questions, but the question that follows a question before it is determined by their response, so that they only get relevant questions. And what happens is that this information is populated into their health record immediately. So the measures are scored and they are in real time available to the clinician and to the patient so that they can center their discussions about any concerns they have with these symptoms, with these care needs, and address any problems that are occurring before they become major issues. We also have automatic alerts in the health records, so if someone has a care need that needs to be addressed, or they have high levels of pain, for example, the oncologist automatically gets alerted. And so this really changes our ability to get patients connected to the right care very quickly. So if they need to be seen by psychiatry or social work, rehabilitation medicine, occupational therapy, physical therapy, it allows us to deploy that care very quickly. And what we know is that the science supports the routine assessment of these kinds of symptoms in cancer care. Patients say that they feel like their care is better. They feel like they're able to talk to their providers in a more effective way. And it actually prevents some complications from cancer treatment that, if not caught early, could affect their ability to continue on their treatment or could impact their care in the long term. So the My Wellness Check, I think, is extremely innovative, and the University of Miami Sylvester Comprehensive Cancer Center is the first place in the country that has implemented this sort of assessment in both Spanish and English to serve the...
Good for you.
Thank you. Yeah, we're very excited. You know, it takes a lot of work to be able to deploy a system like this, period, and then to have it in Spanish and English. But, you know, South Florida is extremely diverse. It's majority Hispanic Latinos, and we also serve people from the Caribbean and from all around the world. And so we want to make sure to make it as accessible as possible. And it's really allowing us to create other innovations. For example, an area of focus for me is individuals living with advanced or metastatic cancer. And we know that when individuals are diagnosed with stage 4, they should be receiving, alongside their cancer treatments like chemotherapy or radiation, care from a palliative medicine team that's focusing specifically on their quality of life, talking to them and their family about their care, and making sure that the entire team is seeing the family and the patient's emotional wellness during that time.
Thank you, Dr. Moreno. That's awesome. I'd like to ask Dr. Sagata to also bring in
I have a question.
Okay, good. All right,
So
definitely.
Is your care delivered telehealth or in person?
For the oncology visits?
Well, for, yes. The program.
So these assessments can be done, it's all online, but they can do it from home before their appointment or when they check in at the clinic. If they have an appointment that's telehealth, they would still fill out the same assessment, and if they're having it in person with their oncologist, it would still be the same assessment, yeah. I think who gets a telehealth appointment versus in person is depending on kind of their treatment schedule and what's happening.
So what's the balance? Would you say you have more telehealth or more in person?
I would say for those undergoing treatment, it's going to be more in person, and then those who are in surveillance or following up with their oncologist, there'll be a combination of telehealth, depending on their screening.
An important point, Dr. Biden, is, you know, in the old days, you'd go and see your oncologist like once every 3 weeks when you were getting treatment, and he would say, "How do you feel?" And you'd say, "I feel okay," and he'd move on, or he or she would move on. And we missed about half of the symptoms. And so this movement to, you know, use kind of the internet and digital tools and cell phones, this patient-reported outcomes movement, is really important. The FDA is really interested in this because it's a way of understanding the toxicity of our regimens. But we find that patients vastly underreport just when they spend 10 minutes with a doctor. And so this is really important to understand the toxicity of our regimens, for example.
Thank you, Dr. Sharpless.
And do you know why liver cancer is the most common cancer?
We're still studying that. We know, but we think there's some synergy going on between obesity and diabetes that might be increasing and impacting the liver. We also know that perhaps the Hep C might be contributing to this, and so we're trying to get more individuals to get the vaccine for those that are age appropriate. So, but Dr. Messon, did you want to add something to?
No, I think it's really a critical piece. You know, we really try to assemble a group of investigators looking into this, because even when we adjust for things like obesity, you know, there do seem to be higher rates. So are there genetic factors within our Latino population? Could there be any environmental overlay? But this transition, particularly from fatty liver to liver cancer, is key. You know, so as a center, we try to look at it from a 360-degree view. We even have possible therapies in development to try to prevent that movement from fatty liver into liver cancer. So we really want to look at it from all angles. Can we prevent it? Can we screen for it earlier? And can we really build further awareness?
Great. And so I'd like to introduce Dr. Sagada, who's going to talk a little bit about the cancer caregiver that complements what we've just heard from Dr. Moreno.
So first off, thank you. Thank you for being here, and Dr. Amadi for inviting me. She forgot to mention that I'm a 2-time breast cancer survivor, 17 years from the first one and almost 5 years as we talk right now. My boys were 10 and 14, and they're now 32 and 28 mechanical engineers and professionals. So I'm more than blessed to be here and sharing this. So I wanted to talk about the unsung heroes of cancer patient journey, and these are the caregivers. Helping your loved one while you have to face shifting roles and responsibilities is a struggle for the caregivers. As patients, we are in control of our decisions, our treatments, and so on. We also want to protect our families, so we keep to ourselves our worries, our diagnosis, our treatments, our feelings. So on the other hand, our caregivers feel helpless and without resources to address these needs. So what do they need? They need knowledge. They need knowledge about the disease, the treatment, the side effects, the palliative care. They need emotional support from friends and family, professionals, and resources to help them deal with the stress, the grief, and other situations. Financial support, and when we talk about Latinos, Latinos have more than one job. So if they're the caregiver and they have to take their partner to an appointment and lose their job, and on top of the cost of the treatment, that is even worse. And they need time to take care of themselves, and most of all, they need to be acknowledged as valued partners in this process. The other aspect I wanted to talk about is patient advocates. Patient advocates have been key players in the advancement of science of cancer. For example, breast cancer advocates have been leaders in achieving patients' participation at decision-making levels in committees such as FDA and NCI. They have been able to demonstrate that they are experts on their own diseases, impacting research, policies, and quality of life of those suffering from cancer. It is crucial for those voices of advocates to be diverse. As an advocate, I have noticed the lack of Latinas and other minorities as patient advocates. Perhaps it's the assumption that no one will listen, or the lack of training and opportunities. My experience has been that people do listen. Having a seat at the table makes a difference. With this in mind, with 2 colleagues in Puerto Rico, I live in Puerto Rico, we did a training for 15 breast cancer survivors to train them about what is cancer and how to be a patient advocate. And it was just before Hurricane Maria, but we did it. And I'm happy to report that 30% of the participants have been able to secure funding in grants or scholarships to attend meetings here in the United States. They had 3 of them have been sitting at patient panels to discuss their aspect, and one of them is actually part of a research committee. So unless we sit at the table, we have to be there. I'm a patient advocate for SWOG Cancer Network, and since I've been there, they think in Spanish once in a while, and it makes it important to understand language is a barrier. Our culture is a barrier for some things. So we need, I can't not do it all. And I can tell you, breast cancer, we have been moving forward, and it's a handful. And maybe 5 or 6 of us Latinas are doing this. And I would live in Puerto Rico where we all speak Spanish. The issue for Latinas here is different, and we have people that don't speak. So knowledge is power, and we have to educate more. So thank you for being here.
Thank you. Thank you. Thank you. Okay. Dr. Fetterman is from UC Davis, and she works in the area of risk assessment, and she's really finding some unique differences within our Latino population. Dr. Fetterman?
First, thank you for listening. Feeling to see that there's an interest for what.
I'm not sure your mic is on. Here you go.
Sorry, I was saying I'm thrilled you're listening, and It's really amazing to see that you're paying attention to this enormous problem. I actually wanted to talk about the disparities in the ability to predict risk that affects Hispanics and other minorities, and where the problem is coming from. And I think there's two main issues. One is the lack of access to high quality care where the prediction can happen, and lack of awareness and education in the Hispanic Latino population about the possibility of using models to predict risk. The importance of prediction has to do both with being able to take action to prevent the disease, as well as know how often you need to be screened for cancer in order to detect it early. And so at UC Davis, we've implemented a program thanks also to the support from the government of California. It's called Tu Historia Cuenta, and it's all in Spanish, designed in Spanish, the team is Spanish speaking like me. And we're educating Spanish-speaking Latinas about hereditary breast cancer. We also just tell them about breast cancer generally and the importance of screening with mammographies. But through the program, we also assess the family history, and then the idea would be to navigate them to counseling and then testing for whomever needs it. And I think that's where we're finding the difficulty. We can educate them, we can assess their risk, but then to take these people many times without insurance into genetic counseling, which is not available in the federally qualified health clinics, that's been a problem. The other issue is the lack of data to develop good models for prediction in diverse populations. And for example, we use genome-wide association studies to find new variants associated with breast cancer risk, but then we use that information for prediction. And the problem is most of the genome-wide association studies so far have been conducted in European origin populations. So not even recent, like a few years back, there was already GWAS studies done in 150,000 cases and controls. Many variants have been identified, but the first GWAS in Hispanics was published in 2014, so 7 years later, and with 1/10 of the power, the population size. So I'm putting together a consortium of Latin American genetics of breast cancer studies so we can share data, and we're hoping to have about 30,000 cases and 30,000 controls to find variants. But this is, after a lot of effort, so I think there's a lot more to be done to really be able to predict risk with precision for all.
Thank you very much, Dr. Fetterman. As you can see, Dr. Biden, we're very passionate about what we're doing here and the fact that they were able to come together for our conference. But I wanted just to share a couple more things that are innovative going on here at the Mays Cancer Center. One of them is that we understand the need for increasing diversity in clinical trials, right? Right now, less than 5% of Latinos participate in clinical trials. So we're using some innovative approaches through social media and communicating with the Latino community nationwide as well as here locally. Latinos are one of the highest users of social media, and so we've developed bilingual and innovative ways and approaches to utilizing them and using real role models from the community to tell their stories, because they can tell the difference between an ad that's paid for by thousands of dollars versus a real person telling their story. And so we have utilized that approach. It's really beginning to bring people into our clinical trials. We're also developing bilingual educational materials to be shown in our clinics as patients wait to go see the doctor, so that once they're exposed to what is a clinical trial, what is randomization, what does all of that mean, so that when they do sit down with the physician and if they are offered a trial, they can make a more informed decision, and then also share that information with their family members if they're there with them, or that we can work it out so that they can learn more about that. So that's really critical. And another area that I think you would be interested in is increasing the diversity of our educational pipeline. Right now, less than 6% of Latinos go on to pursue a higher degree in education, to get a PhD.
I'm all for that,
And so through NCI, we had a program funded that was called Éxito, or Success. And we had a cohort of 200 individuals, and just bringing them and exposing them to Latino role models who have been successful in research. And, we brought them together just for a week and talking about how do you make the application, where do you find the money, and being exposed to some of these successful Latinos. They're going like, I didn't even know people could go into this kind of a field. So 33% of our students have already been accepted or have just recently completed their doctoral program. So we're just really excited about the outcome for that and looking for different ways to continue to sustain it. So these are just a few things that are going on, and we're here to answer more questions if you have any questions for us, but thank you so much for both of you taking the time to be here.
No, thank you. Ned, did you have any questions?
Laura, I wanted you to tell us more about the genetics of cancer in Latino populations and what you've learned from your studies. I think that's been really important work and important for risk prediction, and I wonder if you could say a little more about it.
Yes, thank you for that question.
So I have to say, formally, I was a geneticist, so I think it's really cool.
So the first genome-wide association study done in Latinas that was published in 2014 was done by me and a large team of investigators, including my mentor, Elad Ziv. And we found a variant, so a mutation near the estrogen receptor 1 gene that is only high frequency in the indigenous American component of ancestry of Latinos. It's actually relatively high frequency, 20%, versus 0% in European origin populations or African origin populations, and less than 1% in Asians. And so this is an example of why you need to diversify genetic data sets. This variant could be very important not only for Latinas, but also if we understand how it works, because it's protective. If we know how it works, we could bottle this into some sort of cancer prevention treatment. And there's likely other variants that might increase risk or decrease risk, and we're not finding because we do have 1/10 of the sample size to investigate this.
This is why you need so many patients to find these variants.
You need very large data sets.
But it's very important because that's how we understand cancer in people. So.
But if I may intervene as a patient, right, the access to this testing, when it's in research, it is paid, but part of the cancer care should be having these genetic testing done. And back then, and when I was diagnosed in 2003, having this test was $5,000 that I did not have in that moment. And I had my testing done almost 10 years after my first diagnosis to have access. And then I'm one of the resources one. I work for the university, I have a good plan insurance. I feel I'm one of the lucky ones. That's not the truth. So we're never going to advance the science if we don't open this for the patients. And I'm passionate about that because, again, I feel that I almost had a cold even though I had it twice because I had all the resources, great family, great physicians, but we have people dying because they don't have access, and that should not be it, right? Because it's like you say, it's a villain is going to take away from us, and we need to have that access.
And Dr. Biden, if I may, these doctors and researchers are doing wonderful work. The challenge for us, though, foundationally, it takes a village. The foundational challenge is equity. Getting access to hard-to-reach populations is a little bit about what we talked about downstairs. Those community health workers, the ones that can get the information and get the access to the healthcare out to local communities. We have a huge enrollment campaign every year for the ACA. Texas citizens, Texas residents, in particular San Antonio residents, have high rates of uninsured populations, and those correlate so well with our high poverty census tracts. So we are, as a community, trying to attack poverty from a number of different angles. Our focus is on social determinants of health, but resources and avenues, whether that's direct allocation or something other, to get access to those populations for their health care, health insurance, or community health care clinics so they can get those screenings is critical for our city.
Yeah, and to add to that, Mayor Nirenberg, it's the importance of education and outreach, utilizing our community health workers, but having large community education campaigns, because that's, again, fear in the Latino community. If they're told they have cancer, they just kind of close down, and so we have to open those doors for them and say, we're here to help you. This is how you can have access to care. If you don't have health insurance, how can we partner them with some of our social workers to find some of the safety net organizations that might be able to help us? But that's pretty piecemeal right now, so we do need to do better in getting access to care. Oh. Well, thank you. The floor back to you. Thanks.
I have to, I come at this issue first as a mother and then, as First Lady. And so I have seen all the different parts of this. Like you, we were fortunate when our son got cancer. We had access to the best health care in the world. We had access to trials. We had access to different kinds of therapies. We tried everything. And it's true. You hear that word cancer and you just shut down. You need the patient advocates. We need education. People don't know where to find trials, where to go. They don't know about their cancers. And you're right, Doc. We have to get out in the rural areas, and we've seen this again and again as we've traveled across the country. We have to get out into those rural, underserved areas and to help people. Yeah. And so I think, I'm just so proud of Joe that he's carried on the moonshot, because I think everybody, like I said before, everybody in this room, I bet everybody in this press pool has someone in their family who has had cancer, who's had to deal with this on some level, who has gone, like I have, to a chemotherapy lab and sat there and held the hand of a loved one, or has had to be the caregiver and help them through this and be the mental support. When you yourself think, I'm just, I don't know how I'm going to do this, because I'm working and I'm trying to get the meals on the table and, all the different components of this. Right. And like you said, it's a big part of this is education. We have to get the word out that people have to get screening. Right. And, early detection, and where their cancer centers are, and who their patient advocates are. But it also has to be all evidence-based, all of it. Yes. So our administration is going to keep working every single day, because we know that it affects all Americans. And that's why I want to say thank you so much to everybody here for all you're doing, because it takes all of us. But I really think, we're trying to end cancer as we know it, and I think we can do it. Yeah. So thank you. I applaud all of you.
Thank you. Thank you.
Okay, where would you leave?
And then when she motorcades done, we clear the building, you can come back, get the rest of your gear. Is anybody traveling with me here? Both of you? Okay, I've got my 3 photons downstairs. We have time for a brief break. Okay, everyone in here?
Good to see you guys. Good to see you guys. Fun.
Y el
All
amor,
day.
mira que se estaba bajando el elevador antes del tiempo.
You gonna be able to run it back upstairs one more time?
Yes, sir.
They say when you hear a Mexican say, I wait, because